The reason I bring that up, there's a gentleman who played for for Pittsburgh, and they were going to play in the AFC Championship out in Denver. Pittsburgh was playing Denver a couple years back, and he never knew that he had any sort of medical problems, whatever. They went to Pittsburgh to go play, and I went to Denver to go play. And when they went to Denver to play, he got extremely ill when they were practicing. Well, it took him to the hospital. Come to find out, all these years he never knew that he had sickle cell, and so found out he had sickle cell. What happened? Because of the fact that the sickle cells did not carry oxygen, he's at altitude. He needed an increased oxygen demand that his body could not provide. And they told him, if you were to play, you would die. It could kill you. And so it almost ended his football career. It's just games that he has to sit out because of the fact that he can't play at altitude. But it's normally at normal sea level, whatnot, or where they play. I think Pittsburgh is, a couple 100 feet above sea level, but it's not high, and they're just fine. But once he reached altitude, because Denver is a mile-high city, it's at 6,000 feet above sea level, he couldn't play because his body could not acclimate to that level. And literally, when we got out the car there, we got out and we're like, huh. You just felt like a heaviness in your chest as you tried to breathe. Well, remember Lance Armstrong got convicted of blood doping. What blood doping is when you go train at altitude. So he would go to Colorado and he would go to Seattle and train in the mountains there. And he would ride his bike at altitude, because what the body does is the body begins to produce more red blood cells. So when he would do this, he would ride for hours and hours and hours and hours and just wear himself out, because the body would produce red blood cells, extra red blood cells, and then they would draw his blood. Well, within the days before the race, they would re-inject the blood back into his body, give him a blood transfusion, so that those packed red blood cells that were his were being given to him. That's what's referred to as blood doping. It's against the law, or against the law of the International Race Committee. And so, or the statutes of the International Race Committee. So that's why a couple of his wins were thrown out, and they were giving him a hard time about it, whatnot. But that's exactly what he was doing, was because he knew, or they knew, that if you train at altitude, you increase your red blood cell production. So when it came time for races, that's why he was smoking everybody, is because he'd been training at altitude and he had extra red blood cells. Yeah, but that's why the French guys train in the Alps, because when they ride the Tour de France, where do they ride? In the Alps. So they get themselves acclimated to the environment. They're lucky enough to be able to train there all the time. Okay? So that's one of those things that affects that, is that red blood cell production. Okay? Circulatory compromise can affect it. So if for whatever reason you're losing blood, if you're anemic, i.e. sickle cell, right? Or you have low iron in your blood, it can affect it. That's why you have people with low iron that are always cold and always chewing on ice. It's the weirdest thing I've ever seen. My sister used to do it. And my lieutenant actually does it now. Chews on ice 24/7. And you wonder why. Well, the reason they do it is because water is heavy in iron. And so they chew on the ice because that's how their body gets the extra iron, or some of the extra iron that they need.
Maybe that's why I have really high iron level.
Chew ice all the time? Yeah. That's probably why. It's also very bad for your teeth. Found that out the hard way. Not me, my sister did. And then there's hypovolemic shock, okay? Hypovolemic shock has to do with the fact that you don't have enough fluid to fill the system, okay? You don't have enough fluid to fill the system, okay? And then vasodilatory shock means that your blood vessels have increased in size, decreases your blood pressure. Well, think about it like this. If you have fluid that you have to move through a tube, do half-filled hoses make for good fire ground operations? No. If you don't have enough fluid to fill that hose, is the water going to get to where it needs to be? Are you going to have enough BTUs to put out that fire? No. So, or you're going to have enough water to combat the BTUs to put out the fire, excuse me, terminology. No, you're not. So because of that, we have to make sure that these patients have the fluids that they need in order to do that. Okay, that may be an ALS thing, but they need the fluids. And one thing that we can do as EMTs is we can lay them down. because by laying them down, it causes the body to kind of go into a reset mode. Okay? Some of the trauma that can cause this, and just to give you a list: pneumothorax, hemothorax, hemopneumothorax, or what's referred to as a tension pneumothorax. And when we get into trauma more, we'll talk about those. Okay? So one of the things that we need to look at is assessing this patient. What we want is normal breath sounds, normal respiratory rate, clear and equal breath sounds, equal rise and fall of the chest, adequate depth, and tidal volume. What's our tidal volume normally? How much? Anybody? We just said it.
Oh, it's 500 to 700.
There you go. 500 to 700. Okay? So if you think about that, look at the numbers. 500, so we'll just use 500. 500 at 12 breaths a minute means that we're moving how much? 6,000 cc's of air a minute. 6,000 milliliters of air a minute. So that's 6 liters is what we averagely breathe within a minute. Okay? If we're breathing more than that, that means that typically our tidal volume's not as much. You know how when you start running, you breathe faster? The reason you breathe faster is because you can't get full recruitment of your lungs. So because of that, you breathe deeper, trying to open those lungs, but you breathe more in order to keep up with the same amount of oxygen that your body normally needs. That's how that works. Okay? Remember, in order to know what abnormal is, we got to know what normal is. Okay? We're looking at fewer than 12, greater than 20, irregular rhythm of breathing, and that usually happens because of head injuries or illness like sepsis, diminished breath sounds, or any sort of noisy lung sounds. The thing we need to realize is our lungs are supposed to have a whooshing noise, a slight like when you breathe. That's all you should hear. If you hear anything other than that, you hear a wheeze, you hear a crowing, you hear a crackle, you hear anything other than that slight just, when somebody breathes, that tells you you have something wrong. And there's things that we can do to fix those, okay? So we'll, like I said, when we do the hands-on portion this afternoon, we'll see that. If you see the skin is pale, you see the skin pulling in around the ribs or the clavicles, that means that they have excessive work of breathing, okay? That means they have excessive work of breathing, and that's a problem. If a patient is still breathing after the heart has stopped, this is what's referred to as agonal respiration, okay? That couple breaths they take, they're like, oh, they were just guppy breathing. No, they weren't. No, they weren't. Okay? And this Cheyne-Stokes respiration is what you see with patients with a head injury, a stroke, or potentially a possibly low blood sugar. Okay?
Somebody who's agonal gasping, wouldn't you intubate them?
Oh yeah, they would be intubated because you're working a code at that point. Oh yeah, most definitely. Ataxic respiration. This is an irregular or unidentifiable pattern. This may happen because of a serious head injury. Okay, there's no rhyme or reason to ataxic respiration. Nothing makes sense about it. It's like it absolutely makes no sense. This is metabolic acidosis. Okay, this is your patient that is in DKA, diabetic ketoacidosis. This means they have a blood sugar that is above 300, usually between 3 and 800, and their body is trying to blow off excess sugar. Because it can't pee it off, it can't get it out any other way, so it's got to the point where it has to blow it off. Okay? Yeah, you can smell it. It smells like juicy fruit. I mean, you smell it. Am I lying? It smells like juicy fruit. I'll never forget it. First time I smelled it, I was like, I have the freshest breath ever. It was just the sugar that they were breathing off. Okay? So, again, to know if your patient is properly perfusing, look at the skin. The skin is the window to the lungs. It's going to tell you if this patient is getting the oxygen they need. If their color is anything outside of what it should normally be, you're going to know, and you're going to know very quickly. Okay? Pulse ox is a good sign or vital sign to use. Capnography is a better one. And we're going to talk about capnography this afternoon. Okay? I'll show you how it works. Alright? Or to some degree. And all of these can be used as part of that patient assessment. But the thing I want you to remember is pulse ox, capnography, cardiac monitoring, any of that stuff is a tool. Treat your patient, not your equipment. Okay? The equipment may show something abnormal, but if your patient is sitting there breathing just fine, everything's all good, pay attention to what your patient is doing. Because I've seen people treat the monitor and they're like, oh, such is going on. I'm like, what does your patient look like? Bless you. What does your patient look like? If your patient's normal, your patient's acting normal, all those sorts of things, check your equipment first, because there may be something wrong with your equipment. Okay? All right. And what we're going to do now, let's skip forward a little bit. Okay, yeah. We'll talk about a little bit of this, then we'll take a lunch. Okay? One of the most important things we can do to check the airway is to open the airway. You can't look at it if you can't see it, right? You can't treat it if you can't see it. Well, the unconscious patient should be treated like they have a head injury. Okay? If you have a patient that can't tell you whether they got hurt or not, you treat them like they have a head injury. Okay? We have two maneuvers that we use. Two maneuvers that we use to open the airway. One is called the head tilt chin lift, and the other is called a jaw thrust or modified jaw thrust. Okay? The reason that we use these two maneuvers is we want to keep the patient as still as possible and maintain as much of the C-spine as we can. Okay? The first we use is the head tilt chin lift. This is for somebody that has no trauma. They may be, altered, but we know for a fact that we checked them out, we don't see anything. Okay? What you're going to do is you're going to grab the patient by the head, the forehead, and the chin. And you're going to tilt back just slightly. And what this does is this pulls the tongue off of the floor or the roof of the mouth. So it kind of extends it so it sits more down towards the bottom of the mouth. This allows for that airway to be open. Okay? We're also going to talk about placing adjuncts in the instance that we need them. So the heel of one hand goes on the forehead and apply pressure. The other is